I invite the chairpersons, Dr.T. Vasu, please, Professor and HOD, Department of General Surgery, Azizia Medical College, Kollam. Dr. V.C. Subhash, Senior Consultant, Department of General Surgery, Aster MIMS, Kozhikode. And of course, Professor E.V. Gopi, KMCT Medical College. To chair the sessions, the first presenter, Dr. T.V. Haridas, Associate Professor, Department of General Surgery, Government Medical College, Thrissur. Over to our chairpersons and the first presenter. Time for the kind consideration of the chairpersons, 12 minutes presentation, 3 minutes discussion. Over to you, sir.
Good morning. First of all, let me thank the ASI, Kerala and Casicon, Srijay and team for giving me this opportunity. The topic given to me is evading the pitfalls in the management of soft tissue sarcoma. So some of the pitfalls or shortcomings or things we can improve will be discussed in the following session, like in the following head history, clinical examination, imaging, biopsy and surgery. So as in any other case, a proper history taking and clinical examination is paramount in soft tissue sarcoma as well. You have to properly take a history like a recent rapid increase in size or recent pain, radiation exposure history, or any deep lesion with large size and consistency which is like firm to hard or involvement of neurovascular structures. This type of history should raise your suspicion this could be a soft tissue sarcoma. So once you suspect, the next immediate evaluation is radiology, not biopsy. Many people just jump in and do the biopsy before the radiology. But first thing is radiology. Ultrasound may be the first line. MRI is the standard for extremity, pelvis and trunk. CCT may be preferred in calcified lesions, pleuropulmonary and retroperitoneal lesions. So it is MRI before biopsy. So always remember an extremity sarcoma. MRI, you have to properly interrogate or study the MRI, the surgeon who is doing surgery, about the size, the relationship with fascia, the relation with the neurovascular bundle. And very important is extensive perilesional edema as shown in the previous, for the first top picture. Perilesional edema can have tumor cells which will have to be wide excised when you do the surgery. And the pattern of contrast enhancement, presence of necrosis as shown in the lower picture, middle part of the. So any necrosis, if you plan a biopsy, you should avoid that area of necrosis. So these are some pitfalls which can happen. So this shows the relationship of the fascia and the tumor. On the right hand side you can see the tumor is invading the fascia. So such studies should be made and you have to excise this lesion widely enough to prevent the recurrence. This is again a MRI finding called tail sign. The tumor is extending through the intramuscular plane like a tail. So if you miss this finding carefully, if you don't study it carefully, you may end up with recurrence. So again a pitfall. Remember, biopsy is the rule, no FNAC as you all know. Core needle biopsy is the standard. You may do open or incision biopsy in selected cases. Excision biopsy should be avoided as far as possible, except for very small and superficial lesions. The core biopsy is a rule and should be done after imaging, and you should select areas of more biological activity and avoid necrotic, cystic and hemorrhage areas, preferably done under guidance, 14 to 16 gauge needle. These are some of the guidelines. Sheath needle should be used to avoid needle tract metastasis, 3 to 6 passes from different areas and depths, and you should avoid area of uninvolved tissue planes. Should go directly into the tumor, avoid tissues, areas of uninvolved planes, and should be carried out by the surgeon himself or radiologist. And if you make it in an incision, it should be in the long axis of the limb. And biopsy entrance point should be tattooed so that it can be excised in future, and biopsy tract and scar removed later in surgery. If you're going for incisional biopsy after failure, usually it's after failure of the true cut biopsy, you have to place the incision like this. You can see that the longitudinal axis of this, the limb. No flap should be raised. Adequate representative tissue should be obtained, and you should obtain perfect hemostasis and should be closed without drains. So the left-hand side is the correct way of placing incision, right-hand side is the wrong way. Should never place horizontal incision for biopsy. So frozen section may be used to confirm the tissue representative or adequate, but does not provide complete diagnosis and even may underestimate the grade. So again, it is a pitfall. Frozen section you should not depend too much on. This is again a pitfall. Some benign lesions can be confused as malignant, like cellular benign fibrous histiocytoma, atypical fibrous histiocytoma, lipoma with extensive fat necrosis. On the other way, some malignant lesions may be mistaken as benign. Low-grade fibromyxoid sarcoma is one. But with proper clinical, radiological and histopathological and IHC examination, These type of pitfalls can be easily overcome. Metastatic workup is a frequently asked question whether you should go for a CT chest or X-ray chest only. Low grade, the current guideline is low grade T1 and superficial lesion, maybe chest X-ray is enough. All other lesions, just CT is necessary. Specific histologies, you may even get to evaluate the abdomen. Should you evaluate the regional lymph nodes? These 4 malignancies shown there, they have less than 1% chance of involvement of regional lymph nodes. So CT and MRI in such situation may be useful. Should you go for a sentinel lymph node biopsy? Some papers have come up, but I don't think it's a standard doing sentinel lymph node biopsy in soft tissue sarcoma. Certain malignancies, some soft sarcoma can metastasize the brain as shown there. Such histopathology, you have to evaluate the brain as well. So if you don't do that, it could be a pitfall. Though there are a lot of surgeries in history as well as now described. All these are, most of them are not used these days. Wide local excision and rarely amputation. These are the only 2 surgeries we need to remember. The rule of the day is margin negative function sparing wide excision. That is the rule. That is how you manage a peripheral extremity soft tissue sarcoma. That is the management. And remember, soft tissue sarcoma management always should be teamwork. All the team members should be involved from the day one itself. Pathologist, radiologist, surgical oncologist, and special mention about vascular, plastic, and orthopedic surgeons, because the tumor may be very close to these structures, bone or vascular structures. If you want a resection and anastomosis of the vessels, a resection, you have to get them involved early enough, and rehabilitation as well. So there should be a proper planning in a good tumor board with experienced team, and if you cannot handle a soft tissue sarcoma in your setup, it's better to refer the patient to an expert where it can be managed properly. How much margin is the question. You read many articles, there were 2, 3, 4, 5, but generally now it is accepted 1 centimeter margin is enough. You have to respect the fascian barriers. You don't have to go beyond the barriers and fascia to excise it. Certain situations, even less than 1 centimeter margin is enough. For like to preserve vessels, nerve, or bone, this is called planned positive margin. So when the very close margin, what you do, you can dissect the adventitious perineurium and remove, and the neurovascular bundle structures are examined. If they are not involved, don't have to resect. As shown in this picture, the neurovascular bundle is dissected and they are free, they are left alone. Then after excision, don't forget to clip for the surgical clips at the periphery after excision. This may give you the plane, the area of radiation therapy. And if you're placing a drain, it should be close to the wound edge so that it can be included in the radiation field. These are already, the thick barrier, thin barrier concept, the thick membranous tissue like iliotibial band, presacral fascia, thick barriers. Thin barriers are the weak membranous tissue like muscle fascia, periosteum of adult vessel sheath. What is the significance? The Kawaguchi concept of margin equivalence is thick barrier equivalent to 3 centimeter thickness of normal tissue. Thin barrier is equal to 2 centimeter and joint cartilage is equivalent to 5 centimeter. So what is how can it be translated into clinical practice? If the tumor is removed, the tumor should be removed outside the barrier. The barrier is there, you don't have to go and excise the barrier like fascia or ligaments. And barriers are converted into equivalent distances according to the Kawaguchis, which is I described as just now. Now, certain pathologies, you may have to have more wider margins like dermatofibrosarcoma, protuberance, and myxofibrosarcoma. They are more of infiltrating type tumors. You may need 2 to 3 centimeter margin in these cases. And you can even plan staged excision. If one excision could produce a large cavity, you can do it under staged excision. Remember, the big pitfall can happen in the management. Just for managing, having quality of life, you should never compromise on the margin. Okay. No happiness without life. You have to remember, surgical excision is only the best option. So no compromise on surgical excision, even at the expense of quality of life. And again, how should you send the pathological specimen to the pathologist? Okay, you will do it. You will tag it and send in, put into a bucket and send. I think that is not the way. XY or the relation of tumor to surrounding structures can change markedly. The retracted muscles will open up intramuscular planes, which the pathologist will report as positive margins. So communication between surgeon and pathologist is paramount. Ideally, a surgeon should take the specimen himself to the pathologist and orient it anatomically. Specimen should be fresh, not formally fixed, examined, measured in undistorted fashion, photographed, perform cytogenetic and molecular studies. The closest distance to each margin from the edge of the tumor is measured and explained. Surgeon can discuss the margins of concern, which are the margins of concern, anticipated close-up margin, and structured like intact fascia, which is very important. If you shave off the intact fascia, and the pathologist may report it as positive margin. And margin inking is done only after this. After all this discussion, only should the inking is done. 1 centimeter gross margin is equivalent to about 2 millimeter of pathological. And surgical report, which you write in your request form, should include preoperative and intraoperative diagnosis, surgical contact, contaminations if any, actual completeness, the planned margins and cavity shape if any. And frozen section can be done, but it's unless it changes the intraoperative management, it's not routinely recommended these days. So it can be done if it's re-excision or irradiated lesion. So it is again pitfall, don't depend too much on frozen section. Pathology reports should be based on the WHO nomenclature according to the 2020 guideline. It should include all these so that it can help you in the management. Now, another point is margin positive, is it equivalent to local recurrence? There are 2 large studies. Positive margins, they reported very few cases of positive margin. They concluded by saying positive margin is a risk for local recurrence, but still likely that it may not occur. All positive margins are not the same, like 1, 2, 3, 4. Positive margin like in low-grade malignancy and planned positive margin, the recurrence clear is very low. But positive margin after re-excision for a prior unplanned excision elsewhere, and an unplanned positive margin like a Boop's procedure, like any lump is easily excised. These 2 cases, situations, the recurrence rate is very high, it should not be done. Negative margin, all are equal? Not really. What they see is margins, gross margin less than 2 millimeter had more chance of recurrence, and minimum margin for better 10-year survival was found to be 1 centimeter. There are various studies reported. So currently it's 1 centimeter is the minimum gross margin. So there are various studies which show the positive margin which produces the local recurrence and the state. So the Scandinavian sarcoma group has said that they're giving a lot of importance to the tumor biology. Metastasis is related to the tumor biology rather than the positive margin. So neoadjuvant therapy should be advised whenever there's large or difficult surgery. Radiation, there will be timing, preoperative or postoperative, it's depending on more of the your preference. And so there are some complications, more complications you can occur with postoperative, like the increased fibrosis shown in long-term complications are more with postoperative RT, like increased edema, fibrosis, and joint stiffness and all. So what is the advantage of postoperative RT? If you're preferring for postoperative RT, can it be avoided in some situations? It is possible sometimes. In proper tumor board discussion, in the low-grade and superficial lesions, margins more than 1 centimeter I got with intact fascia and uncontaminated biopsy in surgery, possibly you can avoid postoperative RT. So the final point is follow-up. Most of the malignancy, if the 5-year survival is there, it is equivalent to almost cure. Not in case of soft tissue sarcoma. Even after 5 years, there's a chance of recurrence. So you need a long-term follow-up in soft tissue sarcoma. So summarize. To avoid some of the pitfalls, you need a proper history taken and clinical examination. Radiology should be done before biopsy. Core biopsy and incisional biopsy are the rule. Carefully placed scar and techniques should be followed. Excision biopsy should be avoided as far as possible, and it should be a teamwork of all specialists. Margin negative limb sparing surgery is the rule. And communication with the pathologist and obtaining a good complete pathological report from him, it will help you in your management. Neoadjuvant or adjuvant chemotherapy and radiation therapy should be used judiciously in the cases. Thank you very much for patient listening. And the yellow ribbon represents the sarcoma group, soft tissue sarcoma group. That's what.
Excellent presentation, Dr. Haridas. You are always a part and parcel of all CMEs. And you mentioned that X-ray is enough for metastatic work of, is it CT is not required?
It's only for a very low-grade T1 superficial lesion, very specific indications. In all other lesions, which is larger lesions, high-grade lesions, deeper lesions, you prefer to go for CT. But you can get away with it. CT is always better, but you can there's advice is that small lesions, T1 lesions, X-ray chest may be adequate.
What about vascular surgeons help? At what stage you will?
Yes, if the tumor is deep and close to the neurovascular structures, you may anticipate their help in dissecting out the vascular structures, or sometimes on table you may find the adventitious infiltrator. You may have to resect and reconstruct the vessels. Such situations, vascular surgeons should be on standby. Otherwise, if you do the surgery on table, you decide to get help, they may not be available, so you may end up doing a lesser work. So they should be informed and should be on standby. That's what my point was.
Okay, time is over. One question can be asked from the audience. I think no more questions.
Thank you.
Thank you, Haridas.
Thank you, sir. Thank you so much. May I invite the next